Okay, everyone, we are now live, so you can begin. I know we're a couple seconds ahead, but it kicked in faster today than normal.
Okay, thank you. We'll just wait that extra few seconds to make sure people are tuning in. It's like that really boring part of Instagram videos where everyone's just waiting for people to log in. And I'm sorry if none of my colleagues got that.
Do we actually monitor how many people are watching?
I would say yes. It's a pretty simple task. All right, 11 o'clock, everybody. Thank you. Welcome to the committee PM for, what is today's date? Wednesday, April the 21st, 2021. I will look to the committee for any disclosures of pecuniary interest, if there are any. I have not received any, and I see none. So with that, we will move on. We have an update for the Board of Health from the Medical Officer of Health regarding COVID-19. So I will look to Dr. Renaday if he is on the call. Do we have an update from the Medical Officer of Health today?
There he is.
There he is. Hello, sir.
Hello. Yes, we do. I'll just confirm that you can hear me.
Thank you. Thank you. Yeah, loud and clear, actually.
Okay, great. Good. So good morning, everyone. Thank you. I have quite a few things to tell you today. I'll try to keep them structured, and as with the previous meeting, I will ask to share my screen in a minute so that you can see a few things visually, because I think that helps to illustrate some of the things that I'm going to need to tell you about. So first of all, for anyone who was at this meeting as well as the committee AM, the numbers I'm going to tell you now are different than the numbers that you heard earlier, because our today's numbers just came out, and so I can talk to you about those numbers. So the numbers are slightly different, but you're getting the most up-to-date information as of now. So over the last 24 hours, we received an additional 17 cases. We have had in total 55 deaths due to this pandemic, with a recent death occurring in the last few days. We've had 17 more cases resolve, and so we're at 3,003 recoveries or resolutions. And a total of 293 variants of concern have been detected over the course of this pandemic. Just as a reminder, variants of concern continue to be detected. We will see more and more of these. You're going to see them start to replace non-variants in terms of their prevalence of overall disease. The multiple variants from around the world are identified partly by where they come from, but scientifically they're identified by the kind of mutation that they exhibit. All positive cases go on to be screened for VOCs, and then the labs have different algorithms, that a specific algorithm rather, that they use, whether that then goes on for further testing or is reported back to us as likely to be a particular variant. Most of the variants that we're getting so far are the B117 or the UK variant. We currently have 1 institutional outbreak and 2 workplace outbreaks. But what I would say is that over the last few weeks, our case counts are declining. There's still quite a bit of variability. So some days we'll get 0 or 5 cases. Some days we'll get 10 or 15 or up to 20 cases. But in general, the trend is downwards, and I'll be able to show you that in a minute. You are most likely aware of a number of restrictions that have been put in place across the province recently, and I will in large part, that's to stem the overall tide in the province, right? There are increasing cases across the province. That is putting increasing pressure on ICUs and critical care beds across hospitals, primarily in the GTA. But I will tell you that in terms of the overall health system as it stands, what we're experiencing, or what we're preparing to experience, is spillover effects from the issues that are happening in the GTA. So, from what I understand from our local hospital colleagues, the current status of our hospital is stable. It's okay. We have ICU capacity, we have bed capacity, but increasingly we're being asked to allow that bed capacity to be used for purposes of transferring of patients between different hospitals. So I'm going to explain that in a second. As GTA ICUs and hospitals become overwhelmed, they look to other places to transfer patients. And the first places that they look are other large centers of care. Okay, so you're talking about London, Windsor, etc. The places that those places then look to transfer patients, if they are overwhelmed, is smaller centers of care like Sarnia, like Chatham, etc. Right? And so there's kind of a chain of how these cases flow through the system. So what we're expecting is that every day we might be receiving 1 or 2 cases from regional hospitals that need to send folks to us. The problem is when the system is overwhelmed, 2 things happen. One is that it could potentially limit our ability to transfer out. So to transfer to higher centers of care for people who need specialized trauma, specialized services, that's one pressure. The second pressure is then local pressure in terms of the existing capacity for people here who need to come into the system, right? So the main message that I wanted to share with you is that this is a very critical time for the health system. The science table's findings and projections on Friday were very, very serious. And what they suggest is that over the next 2 to 3 weeks, whatever happens in the healthcare system is essentially unavoidable through any current measures or restrictions that could be taken, because the cases today, the impact today is a result of transmission events from 2 weeks ago, right? So they've already happened. All that transmission has already happened and has created the situation now with rising hospital admissions, etc. So any restrictions that are in place now or significant additions to restrictions are with a view not to changing the next 2 to 3 weeks of health system outcomes, but to changing the outcomes beyond that, to say over time we need to reduce that pressure. But the next 2 to 3 weeks are going to be absolutely critical in terms of what happens in the health system. And that's largely a function of the fact that the more and more people you have, remember, when we take this back to the overall level of disease, most people still do have a very mild illness. Most people still do recover, but a small percentage of people require hospital kind of care. And the more people that you have infected, the more absolute numbers you're sending into that group of people who need hospital level care, right? And so that's really what's happening. This is a result of large numbers of people being infected and a small proportion of them requiring care, but that small proportion being a larger overall number. Okay. So that's really the biggest picture that we're watching right now is the health system effects, but I'm going to transition a little bit and talk to you about vaccinations. I want you to have kind of a clear picture of what's going on there, and then that's probably where I'll leave it. So I'm going to see if I can share my screen with you. I hope that you can see my screen now. Can you see my screen? Yes, okay, good. So the first thing I just want to point out to you is sort of right over the course of May, you can see a peak and then a valley, and we're in the valley right now. And so rather than looking at the individual bars, right now I want you to focus on the line. The line is the 7-day average of cases, and you can see that line trending downwards. That's what we see in our numbers, and that's what we want to keep seeing. So we want to make sure that we stay on that downward trend to plateau out here. But that is not the same as the rest of the province. The rest of the province would see their 7-day averages, increasing in different places, and that's why we're seeing a lot of additional transmission. Okay. I just want to talk to you about vaccines, and in some ways I think that the way that this is, I'm hoping to just present this visually, and I've sort of described it before, but I think it might be easiest to see it in this way. This is an old graph with old data, but the point is still incredibly valid. The point is still the same and relevant today. This is a graph of case fatality rates by age, okay? And so remember, this gray line that goes all the way to the end of the graph is the Ontario average, okay? And what is pulling up the average in terms of mortality is the 70 to 79 age group and the 80 plus age group. Okay, arguably the 60 to 69 age group is also at increased risk compared to this group, but then really the rest of the group 50 and under, there's a slight difference here, but you could pretty much say that this clusters so that the risk is pretty much close together here. So the first priority of vaccines, if this is how I think about them, so take that with, this is sort of my kind of perspective on what we're using vaccines for. The first priority really needs to be to reduce population level deaths. That is the risk of poor outcomes if somebody gets COVID. And there's really good evidence right now that these vaccines reduce hospitalization and death in the people who are vaccinated. And so this, you'll remember, was the very first priority, the 80 pluses and then the 70 pluses, and now we're working through the 60 pluses, right? So that's the first priority. The next priority is, if possible, to use vaccines to mitigate the risk of exposure. That is to say that there are people who either can't work from home or people who are required to be in person for long periods of time with other people, and that they might have an exposure risk. Now, remember, most of those people are in this category, and so their risk of dying from COVID is nowhere near these groups over here. So once you've taken care of this priority up here, then the second priority is use vaccines to mitigate the exposure risk. And there is emerging evidence, though not conclusive, that is possible to do, right? Because what you're trying to say is we may not be able to prevent the exposure, but we can prevent you from having severe outcomes if you are exposed, even though the risk of those severe outcomes is much lower in these groups. And then the overall priority of the vaccine program is to have sufficient overall coverage in the population to reduce mortality, to reduce the burden of disease, and hopefully to prevent transmission and outbreaks. And there's emerging evidence that might be possible, but we still don't know for sure that that's a possibility. Or that's a reasonable way to use the vaccines. And so the real focus is here first, then here, and then over time, overall, to try to achieve sufficient coverage so that even if you're in a situation where the vaccine doesn't prevent transmission and you still see cases and outbreaks, you're not seeing deaths and significant disease in terms of symptoms and care requirements. Okay, so that's kind of how I think through the three major priorities. And if you think about the very first priority, reducing the risk of bad outcomes, and that was primarily by age. In terms of where we are at locally, right, our 70 pluses have definitely plateaued. We're not seeing a lot of additional appointments there, and essentially, we're doing some analysis to identify what the coverage is, but we expect it's at least over 80% in that age group, which is really good. The 60 plus age the 60 plus age group is booking now, and also receiving their vaccines now, and we're projecting a plateau in that group by mid-May. So 60 to 69 and 50 to 59, I think, are the two largest population groups in the county. And so that's a large group of people. So we're projecting that by mid-May, those will plateau off in terms of their bookings. We've also started in terms of the second priority, which is reducing exposure risk, the additional phase 2 congregate settings, as well as immunizing people by particular sectors. To go to phase 3, the population level coverage, again, it's going to take some time to achieve that kind of substantial coverage in the population, but we are working our way towards that goal, with a focus on equity, because we've got urban and rural and mobile clinics. We've got work to reduce transportation barriers. You might have seen a notification from Leo and the Red Cross where people 50 and above who don't have access to transportation can book those services for transport to clinic appointments, as well as working with transit systems and services to alter routes and schedules where necessary to ensure that people can easily access the clinics that we have where transit is available. And then making sure that there's sort of self and assisted booking, right? Lots of ways people can book by themselves, but of course, if people are unable to do that, we can help to assist them through that booking. As of today, we'll have administered over 40,000 doses of vaccine in Lambton County. I think that's a really nice milestone. We're moving quickly towards, each milestone comes along in its time, but I think this is a nice one too. And I think that the real piece for me is that, we've done a lot to reduce the primary outcome risk in the age groups that are most likely to be at risk for those severe outcomes. Now what you're going to see, or now what you are seeing, is sort of a jostling for prioritization based on either exposure or other kinds of risk. But so I want you to just keep in mind, though, that all of that is important. There's a large population there to be vaccinated, but the distinction among who's at risk now is really among a group of people who, by and large, have a far lower population level risk of death. So I think that's a good place to be in, and those discussions will play out. They'll continue to play out, and as they play out in terms of vaccine prioritization, we'll continue to work with new priorities in order to make sure that we vaccinate as many people as quickly as we can. So I've talked about cases. I'm just going to stop sharing, so you should be able to see me again. Can you see me? Yes, okay. So cases, we've talked about outbreaks, variants, the restrictions in the province, health system considerations, which are very significant right now, and the recent sort of update and progress on vaccines. So that's a lot. I think I'll probably leave it there for you, but lots going on, as you can see.
Thank you, Dr. Renaday. That was certainly a lot of information and very much appreciated as always. Not only are you helping to inform us with the latest goings on in our community, but really helping us understand the context in the greater provincial situation as well. So thank you for that. Looking for questions. I saw Councillor Stark had his hand up.
Yes, thank you, Mr. Chairman. To Dr. Renaday, your last segment there showed a completion rate of 40%, or 40,000, sorry. If we back out the number of people under age 16, what is the total, the 100% target of that balance of population? So if we have 128,000 people in the county, subtract out the 16-year-olds and under, what are we targeting as far as 100% immunization?
Good question, Councillor. So we're working with a rough estimate of about 110,000 as the total eligible population. So what you'll see when we administer 40,000 doses is that's not quite 40%. It's sort of 34, 35% because we're looking at over 100,000, but it's just over. That's kind of the rough estimate. So as we move through talking about coverage rates, it's going to be fairly challenging to get the right denominators and the right numbers for those denominators. And so one of the challenges is you can use the old census data, but it's quite out of date. And so it's not necessarily exact. So what we use is growth projections between census to census to estimate what the population in any group is.
Okay, with that in mind, and I know that many people have talked about, herd immunity or whatever the proper term is. If we have 110,000 people, and I'm not sure how the under 16s factor into this, but if we have 110,000 people as a potential target, what number or what percentage of that 110,000 would create herd immunity?
So, Councillor, thank you. It's not entirely clear. It's a different percentage for different vaccines, and it is dependent upon the idea that the vaccine can interrupt transmission, which we do not have enough evidence to say conclusively that that is true. When we have enough evidence to say that vaccines can interrupt transmission, there's emerging evidence, it's coming in, so we have to just see how other places do with this. Then the concept of herd immunity becomes more relevant. And if the concept of herd immunity is brought into the discussion, then the general thinking is at least 70%, but the higher the better.
And finally, with respect to second shots, I fortunately am fortunately or unfortunately, in that above 60 age group. So both myself and my wife have received our first shot. Our second shots are scheduled for August. Is there any science that is refining the effectiveness of the duration between first and second doses?
I think I'm just going to ask if you can clarify the question for me.
Really, the questions that I'm receiving or the unknowns that people are talking about is the length of time between first and second doses. So initially it was supposedly 3 weeks was the optimum time. Now we're up to between 8 and 10 weeks. So the question is, has anything happened to further identify when the most effective time frame is relative to the duration between the first and second dose?
Okay, yeah, that's a helpful clarification. Thank you. So, I mean, I think it's important to remember that the extension of the dose interval was not done with respect to science that suggests that that it's that is an optimal dose interval. It was actually done with respect to modeling projections that say that you get more reduction in disease burden at the population level if you give more people a first dose rather than circling back to give everyone a second dose on time. And so that's really where that policy decision was made from, because in a situation of vaccine surplus, or where you're really not worried about supply at all, the standard practice would be give everybody doses as per the manufacturer's instructions. And so some modeling was done that was shared with all of the provinces that suggested that if you focus on first doses and then circle back and do second doses later at some extended interval, that provides more population level coverage and better reduction in the burden of disease. So I would say that the 4 months is fairly arbitrary, except to say that with the AstraZeneca trial, when they did a sub-analysis by people who got their second dose at 4 weeks, 8 weeks, and 12 weeks, it looked like there was more protection with the people that got their second dose at 12 weeks. And that is consistent with what we know about how the immune function works and how vaccines work. So what you're really trying to do is protect a minimum interval. So you don't want to give that second dose too soon, but after a particular amount of time has elapsed, just as with other vaccines, we don't consider that the first dose or the interval has forfeited. You know, we don't restart you. We just say you're going to get your second dose or you're going to complete your series. So that's how we have to look at this as well, is that really we're looking for people to get 2 doses to complete a series, but there isn't a lot of evidence, because we don't have a lot of evidence with these vaccines, about what the optimal dose interval is.
Thank you.
Thank you. Councillor Arnold.
Thank you very much, Chair Brian. Dr. Renade, I just want to make a comment and then ask a question. And my comment is that I've had so many people that have chatted with me about how wonderful the Lambton Health Unit has been treating the vaccination process with the mobile clinics, the satellite clinics, the way everything's being run in Point Edward, that when you look around the province, you and your group have been leaders in making sure that it got out to people that have transportation issues. And that is a message I hear on a daily basis of how thankful people are of what Lambton County has done compared to many other jurisdictions throughout the province. So I'd really like to just thank you so much and your team for doing that. It's excellent and much appreciated. And the question I have is, I'm just curious as to the percentage of our First Nations people that have now received at least the first dose, because my understanding is that they're one of the most vulnerable populations that we have in our community. And just wanting to make sure that A, they're signing up and getting their vaccinations, and B, exactly how many of percentage-wise have done that and completed. Thank you.
Thank you. And I really appreciate those words. I think we really take that to heart. And so I'll take that back to our team. Thank you. So with respect to First Nations doses, I can say that there has been a really good uptake in the early days. And now each of the First Nations has decided on different kind of models. Some would like to do these mass clinics where they do lots at a time. Others want to have it be more sustainable, where they can have more conversations with people. So each has chosen a different way. I would say that there's been really good uptake at the beginning. And now in some places that uptake is waning, largely because whoever was going to has been vaccinated. And so now it's about further conversations with people who might be more hesitant. In terms of the numbers and in terms of our reporting on numbers, we're going to let the First Nations communities take the lead on that. So we're going to work with them to identify what proportions of their population have been covered and to have the reporting really come through them in a manner that meets their needs. So I can't really tell you exactly what proportion in each community has been vaccinated, because that's really data that rests with the community. And so, we're happy to work with them to share that information and collect it and compile it and all that stuff, but it's really up to them. I would say what we're seeing though is that there's been pretty good uptake, especially in the clinics that have been done, because we work with them as community partners and they're actually helping to organize and run the clinics, and we support them, and those have worked very well. So we've had, I would say, good numbers, but now the numbers, just like with the 70 pluses, are plateauing. There was an initial kind of everybody who wants it got it, and now it's sort of people are still eligible and they're still running some clinics as they need to.
Thank you. Looks like there was a tie. Councillor Cook and then Councillor Broad.
Thank you, Brian. Dr. Renaday, so just following up on Councillor Arnold's comment, the First Nations, are they receiving their doses as part of the Lambton County allotment, or do they receive theirs outside of what we're receiving for Lambton County?
Councillor, I feel like the answer to your question is yes to both. Yes, in the sense that all of the allotments come here first. So we're the sort of central repository, that's the word, repository for the vaccines that come in from the province, right? There are specific allocations that have been made within those for First Nations groups. And so we work with them to make sure that they get those allocations as we are receiving them and based on their ability to use them. But so it's a bit of both. Like we're sort of the place where all of it comes to, but there are specific allocations for specific groups, including First Nations.
Thank you.
Councillor Broad.
Yeah, thank you, Chair White. To Dr. Renaday, I want to echo Steve's comment there. It's probably the biggest single issue that we've had in our county, and I've heard nothing but positive comments from everybody that's attended, whether it's a rural clinic or whether I myself went to the Point Edward one, and what a class act that was. And hats off to your staff. They need to hear that, because it was extremely well run. I was 25 minutes from the time I entered the door till the time I walked out, and it was extremely well run operations. Thank you. My question is on AstraZeneca. It seems like the press has kind of picked on it pretty hard here. Much as I appreciate the information and some of the thoughts on some of its side effects, I think it's probably taken a pretty bad rap. And my question is that affecting the county's ability to give that vaccine out? Like, are people rejecting vaccine because it is the AstraZeneca? How is it affecting our county?
Thanks, Councillor, and thanks for your words there. We'll again take that back to the group. That's been very meaningful to them to know that they're getting such good feedback. I guess I can say a few things about AstraZeneca. I think that the rollout has been complex in terms of, ups and downs in terms of what scientific groups have recommended around its use. And I think that's creating some challenges in terms of how people perceive the vaccine. If you look overall, I think the general consensus is that the risk of COVID disease and the prevalence of COVID disease is much higher than the risk of getting the AstraZeneca vaccine. But again, when it comes down to individual preferences about how to get it, people take into account information differently. So I will say that the challenges to the AstraZeneca rollout have not impacted Lambton County to a significant degree, largely because we haven't received a lot of AstraZeneca, right? Mostly what we're receiving is Pfizer and Moderna. That's most of what we're giving out. AstraZeneca has come through to some pharmacies, and AstraZeneca has come through to us to give to primary care for some of their clinics. So now that the eligibility for AstraZeneca has been expanded to 40 plus, in Ontario recognize that the regulator has said that it's safe for anyone over 18, right? So you might even see some additional downward movement on that eligibility. I think that we're getting more uptake as other places are. So I think what's happening with the other vaccines is that there's more sort of consistent uptake, and the AstraZeneca vaccine has this sort of fluctuating uptake based on there's always, as you open it up to more pockets of people, some portion of that group says, yes, I'll take it.
Thank you.
Councillor Stark?
Yes, thanks, Mr. Chair. First of all, I was remiss in not acknowledging both for the doctor and Andrew Taylor the phenomenal, and I mean phenomenal, service that was provided both to myself and my wife at Point Edward. So I can validate what Councillor Broad has indicated. He indicated 25 minutes. In both my case and my wife's case, that is exactly right. It was exactly 25 minutes, and it was phenomenal service, friendly, welcoming, and for people who are potentially hesitant, believe me, you should not be. This does not hurt. It's extremely user-friendly in the sense that no adverse conditions affected me. I did have a slight sore arm the next day, but Point Edward and the service that came from Point Edward was phenomenal. So I was remiss in not thanking you, and on behalf of my wife and myself, we are very thankful.
Thank you, Councillor.
We'll look for any other questions before I ask my own. Okay, seeing none. Dr. Renaday, just a follow up to the line of thought on the AstraZeneca with the, I suppose supply has something to do with this and its availability, but with the decreasing age of eligibility for AstraZeneca, are there any thoughts that it might relieve the projected pressure on the county-run clinics, noting that a larger portion of the population may be able to receive vaccination through the pharmacies? Would that potentially create less demand for the expected capacity at the county-run clinics? Because we don't even have one of our clinics open yet. If we think about Clearwater, would that have any impact on those numbers?
Councillor, it's a good question. I think it's hard to know the answer, but I think in principle, I would say two things. One, we can't even approach that question with the numbers of AstraZeneca doses that we're getting. I mean, it's so few right now that really we distribute it out to primary care and they give it to some of their patients, and pharmacies get it through a different chain that actually, so that's the one exception to us being the repository of all of the vaccine that's coming in, is the pharmacies get it directly from the province. You know, if there was more AstraZeneca coming in, then it might relieve some of the pressure. However, I would say that in terms of, you know, sheer volume, you know, pharmacies and primary care are really wonderful add-ons to the ways that people can get vaccine. But the way to do the most and the fastest is really through mass immunization clinics, right? And so what I would be saying is where there's a possibility to make use of that delivery model, we'll get thousands out a day. And that's not really the same as you can get by diversifying and putting it into small pockets where they can do, you know, 10, 20 a day, and again, some pharmacies, some primary care, they'll shift their model and do, you know, mini clinics and have, you know, quite a lot go out in a day, but others won't. And so I think, in principle, I think you want to think about the mass immunization clinic as being the primary driver of high volume immunizations. And if the vaccine supply that we get supports that volume, you should push as much to that as you can, and then allow other people to do as much as they can as well, given that they also have competing pressures and demands.
Thank you. And a follow-up to that would be, is there expectation that the county will be using the AstraZeneca vaccine as well, should supply increase and allow for that, or is that simply going to remain a separate stream?
No, we'd certainly be happy to use it as well. Yeah, so it's not exclusive. It doesn't have to go to pharmacies and primary care. It's easier because it is a fridge stable vaccine, and so they all have fridges, and so that's why it's gone out to those places first. But certainly if we get high volumes of AstraZeneca, there's no reason why we couldn't use those volumes in a mass clinic as well.
Okay, thank you. Councillor Broad?
Yeah, just a little follow-up on Dr. Renaday's question there. He mentioned that the stuff that goes through the pharmacy is done through a separate channel. So if we get a report that there's 5,000 vaccine doses delivered to the county, do I take that as that may be more than that because the pharmacy channel is not included in that?
It may be a bit more based on the AstraZeneca allocation. And so, right, that is possible. Yeah, it's probably at this moment not substantially more, but over time if they funnel more vaccines through that channel, then we'll have to work out a way to report both of those things.
Thank you for your information.
Councillor Loosley?
Yeah, thank you, Chairman White. Doctor, I just want to thank you for giving permission to the Petroleum Area Family Health Team to allow them to give vaccinations starting this Friday. And that's for those with down to age 40. So I think that's for the whole area, but that's great. And it's great for, out here in the county, so to speak, or those that can't travel or drive can go to our local region. So thank you for giving us that opportunity. Thank you, Mr. Chairman.
Thank you, everybody. It looks like we've exhausted our questions. That was a great discussion. And again, thank you, Dr. Renaday. And I'll just add on, you've heard it already a number of times, from the tour of the facility came great hope of how this rollout was going to proceed. And I'll echo everybody's comments so far that everybody I've heard from, including my wife, who's in a priority group and has already received a first dose as well. The experience for so many has been wonderful, compassionate, understanding, obviously very timely and efficient. And I couldn't be any more proud of our team there. And again, thank you so much and congratulations and well done. And I know we're still early days, but hopefully we can keep the momentum going, and obviously anything that we can do to support, you know where to find us. But thank you.
Thank you.
Okay, everybody, we'll move on to the rest of the agenda. We're going to look to our long-term care division first. We have 2 information reports coming in, one COVID-19 update and an occupancy for the first quarter report. I'll look for a motion to receive those reports. Councillor Arnold, Councillor Broad, any discussion on that? Councillor Cook.
Thank you, Chair. Just through to Ms. Joris, just congratulations on the work that's being done at the homes. Nice to see that our cases are staying very, very, very low, and that there has not been an outbreak within the homes. If there is anything that's happening, it's staying to one resident only. Just kudos, and again, great work being done by our staff for what they're doing there. Thank you.
Thank you, Councillor Cook. I'll be glad to bring that back to the team.
Councillor Stark?
Yes, through you, Mr. Chair, to Ms. Joris. When I looked at your occupancy numbers, I noted that you indicated that they had fallen below the 97% threshold, and you recognized that there was an exemption to that from the province relative to financing at 100%. My question is, do you have any expectation as to when and if, I know we have a waiting list, so when and if we don't get back to the 97%, do you have any idea when the province is going to impose penalties?
We've, through you, Chair White, to Councillor Stark, we have heard from the province that they will continue to provide us with assistance with occupancy. However, Due to the changes in the hospital situation, we have received information this week that we need to get our beds filled up, and that people in the hospital will take priority. We don't have very many empty beds right now. We were keeping one private room in each home in case we needed to provide isolation for someone in a basic room. But the rest of the vacancies are being addressed right away. So there is some capacity in this sector. In our own 3 homes, we're working to fill the vacancies as quickly as possible.
Thank you. Follow up?
Yes, just to expand upon the penalty factor, if occupancy was at 93% and 97% represented 100% of funding, would we proportionally expect a 4% reduction in funding? Is that how it works?
That's exactly right. Yeah.
Okay, thank you.
Okay, thank you. Any further questions for Ms. Joris? I see none. Okay, I'll call the question. All in favor of receiving these reports? That is passed. Thank you. Any other business for long-term care? Seeing none from the committee. Ms. Joris? None from you? Okay, thank you so much. Thank you for the reports. Corporate Services Division is item 5 on the agenda. There are no reports. Looking to any other business that the committee or staff wish to bring up at this time. I see none from the committee. Mr. Tifo, anything?
Nope, nothing from me.
Great, thank you. Moving on to Finance, Facilities, and Court Services. We have 2 information reports, one on the Bayside Center activity and one on council remuneration and related expenses from 2020. I'll look for a motion to receive both of those reports, please. Councillor Cook, Councillor Ferguson seconds that. Any discussion? Councillor Cook, you're on mute, sir.
Thank you. Through your chair, just another congratulations to staff to see this thing after the protracted, I guess, long-term agreement that took place to get it going where we are, that it's moving forward, and nice to see the work being done at the Bayside Center now. And kudos to staff and everybody for getting this thing moving forward.
Great, thank you. I echo those sentiments. So thank you to staff. The motion is on the floor. Seeing no other questions or comments, I'll call the question. All in favor? That is passed and those reports are received. We have 2 reports requiring a motion, so we'll take those individually. We have the 2020 4th quarter monitoring report. I'll look for a motion to Councillor Arnold, Warden Marriott, on the recommendation there. Any discussion? Seeing none, all in favor? That is passed. And we have the 2021 tax policy report with a recommendation. I'm just flipping through my pages here. Yes, a series of recommendations there. Looking for a motion on that. Councillor Broad. Seconder, Councillor Bushi, thank you. Any questions? Seeing none, I'll call the question. All in favor? That is passed. Is there any other business from the committee under Finance, Facilities, and Court Services? Seeing none, I'll look to staff.
I just want to say thank you for this support on the 4 reports, especially Councillor Cook's comments on Bayside. As the county, we're very happy to see that moving along in after a long haul and in the timelines that they've that we're under, as well as tax policy. Just on that 4th report, as a county, we collected our $82.2 million in March, set in the budget. tax policy is a very important aspect of managing fund collection and so forth. So appreciate the support.
Excellent, and thank you for the good news on the surplus as well. Well done navigating this difficult previous year that we've gone through. So thank you again to staff for all your hard work on that, and we'll say good day to you, sir. We appreciate your time. And moving on to Social Services Division, we've got 4 information reports. Maxwell Park Place Affordable Housing, implementing action items from the Housing and Homelessness Plan report, Ontario's Vision for Social Assistance Transformation report, and the Social Services Relief Fund. So I'll look for a motion to receive those reports, please. Councillor Stark moves that. Warden Marriott seconds that. Any discussion? Councillor Stark.
Yes, thank you, Mr. Chair. And this would go through, I presume, to Ms. Colasante. My first question, and I do have a few, relate to page 33 and 34. I'll deal with 33 first. Who comprises the Lambton County Housing and Homeless Advisory Committee?
For you, Councillor White, to Councillor Stark. The committee is made up of nonprofit agencies and community partners that provide housing or homeless services within the county. So, for example, the Inn of the Good Shepherd, CMHA, Rebound, all the organizations that provide those services.
Thank you. On page 36, under your consultations, you indicate, among many, that consumers, who I'm interested in who the consumers would be, local municipal staff and politicians. So again, my question would be, what or who are the consumers? I presume the local municipal staff refers to all of our municipalities. And finally, what politicians were consulted on this?
Through you, Councillor White, to Councillor Stark. Just so that I can confirm, you're asking about the report to implementing actions from the Housing and Homeless Plan?
Well, actually, I believe it involves both, but I'm interested in the consultation process in general.
Okay. So in 2019, we hired a consultant and underwent extensive consultations for the Housing and Homeless Plan. So we had a number of community consultations. We had a number of ones that were open to anyone from council to the general public. There were quite a few different consultations, as well as an online survey, I believe. And that was all pulled together by the consultants to come up with the recommendations that were presented to council in June of 2020.
Thank you. And finally, and this goes back to page 34, we talk about, and in the conclusion section, you mentioned that the County of Lambton Housing and Homeless Plan 2020 to 2024 sets a strategic direction for housing and homeless work. One of the key milestones is that by 2024, 75 more affordable housing units will be built with the assistance of government funding. So using that target of 75 and subtracting the 24 units that are planned for Maxwell Park Place, that leaves a balance of 51 units with, the way I calculate it, 2.5 years to go in terms of your target stream. My question is, do we have an actual plan to accomplish those 51 units, or how are we going to get there?
You, Councillor White, to Councillor Stark. That's a really good question. When we did the Housing and Homeless report, I believe, and I don't have the report in front of me, but I believe it indicated, based on what our core needs strategy was, that we required just over 300 new affordable units within the county. So we worked backwards a little bit and tried to come up with a figure that appeared to be achievable. So are we on track? I think we are. with the 24 units that'll be done this year. We've applied for federal funding to assist us with this build. We're waiting to hear. There were new dollars announced in the federal budget yesterday under this particular program. So if we can receive some federal dollars, we may be able to reallocate other county dollars towards another build and start looking towards another build. We're also hoping to work with private sector. So we have some ideas, but we absolutely will need additional dollars from both the province and the federal government. So we don't know for sure that we're on track, but we also felt if we didn't put a goal out there, we needed something to work towards. And we wanted a goal that was achievable and not too grand of an idea, but hopefully we can achieve this by the end of 2024.
Thank you, and thank you for your work to date. This, as you know, is a significant priority for myself, but for many others. And the issue of homelessness is affecting all of us, whether we want to believe it or not. The fact is that these people need help, and we are the ones who are supposed to provide the help. So I can't thank you enough for the work you're doing and how important it is. Thank you.
Set on to the team.
Thank you, Councillor Stark. And just as a follow-up to your one question to Councillor Stark, I was in attendance at the one public session for the housing and homelessness consultations. It was a very large gathering of people there. I know we were all invited. I do recognize that there were several other members of lower tier municipal councillors there as well. So just to help fill in that gap for you. We have Councillor Boucher and then Councillor Cook. Councillor Boucher?
Yes, I have, first of all, I want to tell you that the reports was excellent. I mean, they were very good and they explained everything. Thank you very much for the reports. The thing that was missing in my mind was the things that coming up, the buildings and what we have now. Could you give me an idea, or do you know exactly what is, when you mean low income people going to affordable housing, what rent do they pay?
Through you, Councillor White, to Councillor Bushy, I'm going to call on our manager of housing, Kelly Hall, to answer that question. Kelly could join us.
Thank you.
Thank you. Through you, Chair White, to Councillor Bushy. Typically in the affordable housing units, council has...
I don't hear you too well. Could you raise your voice?
Can you hear me better now?
Yes, yes.
Okay. Typically what has happened in the past with all of our affordable builds, council has approved for what we call a bridge subsidy, which actually offers a deeper affordability for the tenants that are moving in there. And so the tenants that have moved into the majority of the tenants that have moved into the affordable units pay rent that is geared to their income. So approximately 30% of their income goes to, it would be what their rent charge would be. If they're not receiving the bridge subsidy, the affordable housing rents are set at 80% of the average market rent.
Okay.
You can't tell me approximately how much they pay.
$9.
It would depend on whether it was a senior person or if it was somebody who was in receipt of Ontario Works or Ontario Disability, or if they had employment income. It would be about 30% of their average rent, or sorry, their average income for their rent.
Okay, thank you.
Councillor Cook?
Thank you, Chair. I guess through to Ms. Colasanti. I note in Committee A this morning, they're looking at tiny homes as part of their initiative, part of the package in that overall agenda package. Is that something that the county would be interested in looking at for potential housing for, I guess, less inexpensive housing as if they're doing tiny homes? Could they set up an area that could be designated for the geared income folks?
Through you, Councillor White, to Councillor Cook. Again, I'm going to call on Kelly Hall to approach that about what provincial funding may be available.
Through you, Chair White, to Councillor Cook. certainly the funds that we've received through the Ontario Priority Housing Initiative as well as the Canada Ontario Community Housing Initiative could go toward tiny homes if that were an initiative that municipalities wanted to support. And certainly implementing the housing and homelessness plan, it speaks to the report on implementing the housing and homelessness plan speaks to kind of addressing some of those needs. We've been working with planning around that report and hope to be able to bring more information about that through the consultant.
Thank you.
Thank you. Any other questions? Seeing none, I will call the question. All in favor? And those reports are received. That's passed. We have one report requiring a motion. That's the Homelessness Prevention Team Staffing Report. Look for a thank you, Councillor Broad. Councillor Cook seconds that. Any discussion? Councillor Stark.
Yes, as I read the report, it appears that the province is stepping in to assume some of the, we'll call it back office support, such as finance and those sorts of things. My question then is, if we're adding $120,340 in terms of a staff person, and the province is now going to assume some of the back office costs, how does that impact our local operations, and does it lead to a potential savings in manpower as it relates to the finance department or whatever else? What I'm trying to get at is, I understand the financing or the subsidy in the short term will cover the 120,000, or you're going to find a way to cover the 120,000. My question is, are we locking ourselves into a full-time position moving forward that is not being offset by potential savings? Thank you.
For you, Councillor White, to Councillor Stark, you're referring to Ontario's Vision for Social Assistance Transformation Report, and you're correct. When we talk about the province will be assuming some of the back-end duties and taking on a little bit of the centralized intake, that's going to happen over the next 2 to 3 years. When we look at the Vision Placemat, they're starting right now with things like electronic data management and a little bit of centralized intake. So we don't know exactly what the vision looks like. We know that the work will be shifting a little bit, but without having all of the details, we aren't sure. But your question is certainly a good one. Are we locking ourselves into something that we may not have the dollars for down the road? We think that the work will shift, and this particular position is an integrated position. So it will work both with our growing homeless population and the growing homeless team, as well as with Ontario Works. And that's exactly why we made it an integrated position. We feel that homelessness, the work being done, is very much the work Ontario Works is already doing around life stabilization. Certainly you can't find a job if you don't have a house, if you don't have somewhere stable to live. So by making it an integrated position, we think that that is sort of looking down the road towards that vision. And if for some reason there were staff reductions, we think that would be handled through attrition. So if in 3 or 4 years, things change, we think there would be some attrition. So we would take a look at staffing all the time, of course. Every time someone retires, we take a look at staffing.
Follow-up?
Yes. First of all, I like the direction. I think that you're moving towards this cross-pollination of functions, and that to me is very productive in the longer term. I guess my concern or my observation is that we wouldn't want to lose sight of potential savings, and by the sounds of your attrition idea, you're not losing sight of those. I do like the idea that we're paying closer attention to bringing together all of those issues. So my compliments. Thank you.
Thank you. We have a motion on the floor for the recommendation in this report. Any other questions on that? Seeing none, I'll call the question. All in favor? That is passed. Is there any other business in regards to social services? Looking to the committee. Seeing none. And to staff.
I don't have anything else to add. Thank you.
Great. Thank you so much. Thank you for your time today. All right. Well, that brings us to our in-camera report, for which there is none because we didn't meet in camera. And with that, I'll look for a motion to adjourn. Councillor Broad, Councillor Bucci seconds that. Any discussion? Shockingly none. All in favor? We are adjourned. Thank you, everybody, for your time.
Thank
Stay
you.
safe.
Thank you. Take care.
Have a good day, everyone.